Bharadwaj, your host for tonight and a proud volunteer at Project Step 1. I welcome you all to another fabulous webinar session on musculoskeletal problems in home care based primary care and role of physiotherapy in the era of COVID-19. I welcome our speakers for the evening, moderator, Dr. Ramkrishna Prasad, who is the founder and director, PCMH Restore Health, Vice President, AFPI Karnataka, Dr. BK Rao, who's a family physician and mentor at AFPI Karnataka, Dr. Ashutosh Kaur Anand, who is co-founder and director of Aveksha home-based primary care, Dr. Kolas, who's a physiotherapist, PCMH Restore Health, and Dr. Prathamesh S. Sawan, co-founder and lead clinical pharmacist, Aveksha home-based primary care. So before we start today's session, a small introduction on Project Step 1. Project Step 1 now definitely doesn't need any introduction, but Project Step 1 is a volunteer-driven non-profit collective of individuals from the startup community with the volunteers and doctors from across India to provide free access to healthcare via telemedicine to the citizens affected by the COVID-19 pandemic. The ongoing COVID-19 has made humanity face unprecedented crisis, but our doctors and the medical team have proved to be the heroes over the past 8 months. Our Project Step 1 doctors have made great impact on 5 million lives and have done more than 900k teleconsultations and have been successful in preventing more than 500k contacts. Dear doctors, Step 1 and the citizens need just 30 minutes of your everyday life. Your 30 minutes can save thousands of lives. Give us a missed call on 08047192219 to join the largest doctor volunteer group. About today's webinar. This webinar, let's understand the common problems affecting muscles, joints, and mobility, especially in the elderly, that has become a major challenge during COVID-19 as movement routines have been disrupted. We will discuss several cases and highlight how family physician and physiotherapist can assist. Over to you, Dr. R.K. Prasad.
Thank you very much, Shruti, for firstly the opportunity for us as a group, as a team, multidisciplinary team to present this. Also, thanks for the introduction. Could I have the slides that we've made projected, please? Okay, welcome everyone. I think this is a unique opportunity. A session like this is unique for, I would say, 3 reasons. The first reason is it brings together members of the community, society at large, along with doctors and other healthcare professionals. And it also provides an opportunity for multidisciplinary teams like our own team, which has a clinical pharmacist, a physiotherapist, physicians who've been in practice for several years and who may have different flavors of practice together on this platform. I want to specially extend my appreciation and gratitude to the Academy of Family Physicians of India. AFPI has emerged as the premier academic body to represent the interests and goals of strengthening primary health care and family medicine in India. And thanks to the growing AFPI movement, we're very happy to be able to get these opportunities to project and promote family medicine and showcase its value to society at large. Today's session, we focus on musculoskeletal problems in home-based primary care and the role of physiotherapy, particularly in the era of COVID-19. Next slide, please. Next slide, please. The objectives of this session are threefold. Firstly, using a selection of case examples from our daily practice, we want there to be an understanding of the burden of musculoskeletal problems in the community. We also want to highlight the critical role patient education, family physicians, and physiotherapists play and can play in preventing loss of mobility, loss of independence, joint pain, joint stiffness, muscle loss, and restriction of function, especially among the elderly. And lastly, we want to demonstrate through Dr. Rao's video a simple and easy sequence of daily exercises to preserve and enhance function, which is applicable at any age or stage of life. Next slide, please. The slide before this, please. There should be one more slide. Okay, go to okay.
Hi, good
Is
evening.
we'll start with a patient story. This is Mrs. Brahmra, who is 71 years old, and she's been very kind to share her experience as a patient with all of us. Thank you. Kindly go ahead and you can play the video.
I'm 71 years old and I would like to share my few feelings with all of you. On 11th November, I had a fall in my bedroom and there was great difficulty. I couldn't even get up and I couldn't sleep. Night I was anything. And my husband had to take me to Vikram Hospital in the evening in ambulance because I couldn't move at all. They had to put me in the stretcher and take me there. Then night 11 o'clock, they brought me back home, and then Dr. Ramakrishna visited us on 12th November, and he was worried looking at me because I told him that I didn't go to toilet at all because I was going to depend on others, and that's how I didn't drink water, I didn't eat properly, but then he convinced me and somehow I managed. And then on 13th morning, Dr. Ashujish and Dr. Prathamesh came home. They visited, they examined me, and I am a diabetic patient, my sugar levels are under control. And then since 13th November, Dr. Kohli.
Okay, thank you very much. Can we go to the next slide, please? So we listened to to Mrs. Brahmra, and many people who live in the community can have issues like this on a daily basis. The flow of our session today, very briefly, so that you know what to expect. After my remarks, I will invite Dr. BC Rao to set the stage for today's session. Why this topic and why this topic now? Then we'll have Dr. Ashujit Koranan use a case to illustrate and highlight certain common challenges which are encountered in home-based primary care. We'll then invite Dr. Prathamesh Sawant, who's a clinical pharmacist, to speak very briefly about the pharmacotherapy used for musculoskeletal issues, and particularly when good becomes bad. Then we'll have Dr. Kolis, who's a physiotherapist and who's a very special physiotherapist because he works closely in collaboration with family physicians. And he also makes home visits and provides people home-based physiotherapy. We'll have him share the approach to physiotherapy that he employs. Then we have Dr. Rao give us the family physician's prescription, and he'll demonstrate to us some simple exercises designed for people to stay healthy. We have about 20 minutes for moderated audience questions and answers discussion, and finally we'll conclude. So this is the flow of the session. Next slide, please. So now, without further ado, I invite Dr. BC Rao, who is a legend in family medicine, to set the stage and speak about why this topic and why is this topic valuable or useful at this time. Over to you, Dr. BC.
Thank you, thank you, RK, for that introduction. Now, if someone observes a human body, you can visualize and see that it is structured to move, and movement is the essence of life. It's at all levels. It is true for us, it is true for all kinds of lives. Now, movement depends on many structures. Predominantly, primarily it's bones, muscles which drive the bones, and the joints. Now then, there are other factors also here, like the nerves and the vessels that supply the sensation and take the sensation, and then the blood that comes in and goes out. So this is the structure designed to move. And then it is not necessarily during COVID times, but it is at all times that we need to move to survive and remain fit. What has happened over several decades, that this movement has become less and less, and then virtually when you retire, it becomes virtually zero. Now, the COVID situation has made it even worse for the elderly, because those who are above 60, they are prevented from going out, they are prevented from getting into buses, public transport, the metro, and then they are made to stay home for their own protection. That is good as it may be, but then comes the question what these old guys must do. That is the question we are trying to answer today. And then hopefully at the end of it, those who are watching this will be benefited as to what they should do in their own homes to remain fit. We will try our best to give you certain tips, and I have made a video of myself doing those exercises, and that after playing the video I'll explain a bit about how best to do it, because this is done in a kind of a fast sequence. And then I also request the audience to realize that this is not just enough to watch that video and do it. There are other types of exercises also they must do, and then usefully utilize their time in their day-to-day lives so that they remain fit and prevent illnesses that would accrue if you don't move your body and joints, like osteoporosis and osteoarthritis of joints, of the knee, hip, even your fingers actually, and thus try and remain healthy, not only during these times, but for all times to come. Thank you. Okay, back to you.
Thank you, Dr. Rao. Over to you, Dr. Ashujit. Dr. Ashujit is a community medicine, family medicine, and palliative care physician who is the founder and director of Aveksha, which is a home-based primary care service. Dr. Ashujit, could you illustrate to us what are some common challenges that you encounter in your home-based primary care practice? Thank you.
Muscles, ligaments, all these are major issues with the elderly, but it has become a challenge with even others who are not elderly but homebound during this COVID time. And during our home visits, we find that a lot of people have issues because they are unable to move out. They have stopped doing their regular exercises or even taking a stroll outside. They are unable to, meet people. So the human interaction has come down, which causes a lot of mental health issues. Then there is, with the elderly, there is a lot of isolation because they are homebound, they are not meeting people. Whereas the other generation is still working from home and they still are doing some work, but elderly find that they are just homebound and not able to involve and indulge in any other activity. So there is a lot of mental health issues with them. Yeah, I will just illustrate the common challenges we encounter. So, because the mobility comes down, there is their nutrition, the appetite is affected, and they don't feel like eating, or they eat too much. There is issues with weight loss, muscle loss. All these issues are there, which we encountered in our home-based care. I will just illustrate with a case here. Can I go to the next slide, please? Yeah, the next slide. So I'm just showing here as to what our model is. So we provide integrated multidisciplinary care, and which is personalized to every individual we visit. It's individual and family. So we have the physician, the clinical pharmacist, there's a psychologist, physiotherapist, and we also have a network with specialists and hospitals where we can refer a patient, and patient is referred back for a home care from the hospital. We have tie-up with laboratories where we have home collections. The person goes to the home with all precautions, due precautions taken, especially during these COVID times, because a lot of people do ask us, how do you ensure that the person coming to us is not COVID positive, or we are not at a risk of becoming positive? So we do have protocols in place where the person goes with the proper PPE, ensuring that he is reducing the risk of transmission to the elderly whom he's visiting. We have nurses across the whom we have tie-up with. So in case a patient needs to be given IV injections or a dressing on a regular basis, then we have these nurses who travel to the patient's home to provide this nursing care. Yeah, the next slide, please. So here I have a small story where it's Mrs. Gupta, who's a 91-year-old. She was referred to our Aveksha, the home-based primary care, by Dr. BK Rao, whose patient she has been for many years. She has been considerably active, lives by herself, cooks a little bit, and walked around without support. Suddenly, she complained of severe low backache, inability to move, and a constipation of 4 days. Dr. Rao immediately suspected a vertebral fracture due to chronic constipation while she was trying to empty her bowel. She was referred to a tertiary care hospital by Dr. Rao to get an X-ray done. The X-ray revealed a fracture of L3 and 4. Following this, her 2 daughters and the son moved in to take care of her because she was living by herself all these years. And then Dr. Rao asked us to visit her and see what can be done to provide her the care, and also to teach the family how to care for her during these times when she has sustained a fracture and is almost bedbound. So during our visit, she complained of severe pain on movement in the bed. She was very disturbed. She just kept saying, I have pain, I have pain. She was disturbed mainly because she could not walk and she could not use the toilet. Her concern was mainly that now she has become bedridden and she is going to be dependent on her daughters and son for her daily activities, which she really didn't want to. She kept telling me that give me something so that I don't have to go through this and I can just leave the world. I talked to her, spoke to her, and made sure that I told her that I will ensure that she is pain-free and comfortable till the time she is on the bed. And soon she would be able to move out of the bed and not be bound to the bed forever. Of course, she did not take it at the first go. We advised her rest for 6 weeks, no weight bearing, as the pain was of the severity of 8 to 10. The children felt that she has more of psychological reasons to feel the pain, but actually the pain is not so much. She complains of pain only when she has to eat or she has to turn around. Whereas we, as physicians, we go by what the patient says. We believe the patient. So, believing her, assessing her pain, it was 8 by 10. Now, it was more important here to take care of her other needs and her other general health. So, we taught the family how to massage the skin, the pressure areas, to avoid any bed sores. And then the laxatives so that she does not constipate, because here she's not going to be moving around, she's going to be in the bed. Her bowel movements are going to be really difficult and she might get more constipated, which she already had. So, how to avoid that? Nutrition part. Now, she was not able to sit up. So, we told them that she can just incline her bed a little bit so that she's not lying down flat while she's eating. She should not aspirate. So, all that was showed to the family how to do it there. And then told her how to do a little few of the passive exercises, not really exercises, but movement of her shoulder joint, her elbow joint, her knees, ankles, so that she does not develop stiffness and also to avoid muscle mass loss. The pain, for her pain, we made sure that she's pain free. So we started with the diclofenac patch, which reduces the pain considerably. And we told the family that they can give her a Ultraset at night if her pain is unbearable and she's unable to sleep. She did pretty well with this for 6 weeks, and was then, after 6 weeks was the time for her to get out of the bed. That's when we referred her to Dr. Colas, our physiotherapist here, for some muscle strengthening exercises and mobility, mainly mobility to get her out of the bed, and then to how to start with the exercises. And with his intervention, she's now walking around with a walker to the bathroom, around the house, feels much better. I still remember when the first day I got her out of the bed onto the chair, she gave a broad smile and she said, "Yeah, my pain is there, but very little, not as much as it was on the first day." And her mood is much better, of course. So, yeah, that is so this is just one story. We have plenty like these where the patients have had falls or the patient has other issues due to not being able to move around, and Dr. Colas does intervene with his physiotherapy and improves the quality of life. It's very important when a person feels that they are not dependent and can move around, even if it is in the constraints of their homes. Yeah, thank you.
Thank you very much, Dr. Ashijit. Dr. Prathamesh, now you are a practicing clinical pharmacist and you're integrated into a family practice team and you accompany Dr. Ashijit on home-based primary care visits. Could you shed some light, throw some light on what are certain challenges you encounter in terms of pharmacotherapy, in terms of the use, overuse, misuse, inadequate use of medications in this setting? Thank you.
Thank you, Dr. Ashley. So yes, absolutely. Can we move to the next slide? Yes. Understanding pain and treating it is really critical and challenging, especially when it comes to elderly, as they come with diverse comorbidities like hypertension, diabetes, osteoarthritis, rheumatoid arthritis, kidney and liver or lung diseases. So to treat all of this, they would be on a bucket full of medications. Now, pain is also associated with other morbidities like limited mobility, depression, and social isolation, especially when it comes to elderly care. During the era of COVID-19, as highlighted before, there has been disruption in procurement of medications, access to care, especially the healthcare, and increased self-medication due to the stigma of carrying risk risk that elderly carry while they move to a healthcare professional or hospital for acquiring infection. So during our home visits, we see several such patients with medications like Voveron, Ibugesic, Brufen, Dolo, Hyphenac, Ultracet, etc. in that pill box, which they usually take to manage pain. Most of the time, prescribing and procuring these medications would be easy, but making them work right is truly a difficult task. Now, treating pain always happens when we try to treat the actual underlying root cause. Most of these medications superficially reduce the pain signaling, but often do not treat the underlying cause. So, to add on to all this, these medications can also they also come with their own adverse drug profiles and drug recurrent gastritis, peptic ulcer diseases, etc. Coming to drug interactions with it, now since most of these patients would be on polypharmacies, there are several drugs that interact with these medications. Also, the disease that they carry through can also interact with these medications. For example, these non-steroidal anti-inflammatory drugs like ibugesic and others can aggravate venous thromboembolism and increases the chances of patient to have furthermore clots and cause furthermore issues at places where you don't need to. Also to note is the reduced or compromised absorption, metabolism, and excretion of these drugs when it comes to elderly due to the age and other comorbidities that they carry with polypharmacy. All this affects their homeostasis and reduces their ability to reduces the drugs availability to work right. Taking an example, most of these elderly have reduced mobility or motility of the gut, so they are more prone to have constipation. But using drugs like Ultracet, which are most commonly used for pain management, especially in bed-bound patients, can further aggravate this constipation. To treat this, patients put on laxatives, which can lead them to have diarrhea. Patient can land up with dehydration and other issues. So, helping patients come out of all this vicious cycle is by educating not just the patient but also the family of the caregiver or patient's close ones to rightfully go approach a physician, that primary care physician or any other healthcare providers before using any of these medications. We have also used certain different route of administrations, like using a patch instead of a tablet, to overcome several gastric issues or to avoid these other side effects of these medications. Also, when it comes to the drugs like morphine, pethidine, and fentanyl or other opioids, most doctors fall in a dilemma of dependence, tolerance, and addiction. But most of these medications, when used for pain, especially in higher doses, do not have not been actually seen to cause any dependence. Overall, we as healthcare professionals sometimes may not have answers to pain, but understanding pain and empathizing it with the patient, providing the right treatment through choosing the right medication, right route of administration, dose, and frequency, integrating all this with a non-pharmacological approach like physiotherapy can actually help build the patient's confidence and help fight pain and try to rule out the root cause of the pain. Especially in a multidisciplinary practice like this, it can help identify and rule out the basic cause for the pain. And this approach can not just help better outcome, but also enhance the quality of life. At the end, it's the journey that truly matters. Thank you.
Thank you, Dr. Prathamesh. Next slide, please. Now I invite Dr. Kolis to share his experience and expertise on the physiotherapist's approach. Please go ahead, Dr. Kolis.
Thank you, Dr. R.K. Prasad. So, next slide, please. So,
So Dr. Kohli
so we'll
has
start.
been treating me since 13th November. A person who couldn't even move. Now I can walk on my own, I can climb up the stairs, I can turn on my own. I don't need anybody's help. And he is excellent in his treatment. And first thing is he's so punctual. So we both, that is my husband and I, we are maha impressed with police and such a soft spoken person. And that's what we see in every doctor, because 50% of the disease vanishes when a doctor is soft spoken and he listens to you. So I'm very grateful to Dr. Kohlis. Thank you very much. God bless all of you.
Uh, so, this is what a team does to a patient. A single person or a single professional just working with one patient will give you a limited results. But if you have a team who approaches a particular problem together, this is what we get. So I'll just want to take a small case study to explain exactly what is a physiotherapist approach to a patient. So we'll take an example of a patient who's age 71 and her body build is mesomorphic, which is basically the patient is not that obese, nor are they that thin and bony which they can't recover. So the day when I went and saw her first, when Dr. R.K. Prasad gave me the reference, so when I went and saw her, she couldn't even move, she couldn't even stand. So our assessment criteria is based on two important aspects. The first one is what we identify as the nature and the extent of the patient's impairments. Now, as in how we get the case, the diagnosis is already made. So that is not an important aspect for us, but rather understand the patient's impairments and what's the damage which has already been caused to the patient and how we can identify the nature of the problem itself. And second is the restriction what the patient is seeing. For example, if I've seen the video, the patient was saying that she couldn't even stand, she couldn't even move, she couldn't even, the very idea of just walking was painful for her. So we understand what is the restriction of the patient, and then we work on that aspect within the patient's context itself. Every patient is unique. Now, if we ask a bodybuilder to just go and clean the house, he will not be able to do that or cook food because that is not his context of work. So we look at it depending on the patient's context, what he requires and what he or she requires. Next slide, please. So our assessment criteria is based on that. And as we go forward, and during my assessment finding, I found few important aspects. That is, the patient wasn't even able to move. Her bed mobility was zero because of severe pain. Her hips and knee movement was completely restricted because of the pain which she was feeling. And she wasn't even eating food or drinking water because the very idea of just getting up from the bed and going and using the toilet was too painful for her. She couldn't even, it was that difficult for them. So so what I did on the day one is I assessed, I found out what's the requirement, what is the patient's requirement, like what is her goal and what was her functional requirements. Like she wants to cook food, she wants to clean the house, she wants to go and go for shopping or just ride a bike, depending on the patient's requirements. Then we find the approach. Now, on the very day one, when I looked at her, the very idea of just standing up and going to the kitchen was a nightmare. So then we need to find approaches, or we need to find the ways of taking the patient to that aspect of it where she can do everything on her own independently before the entire incident itself. So when we look at the patient's approach, or when we look at the treatment approach, we keep three things in mind. One thing is how do we relieve the pain of the patient? And second is how do we achieve and maintain the mobility what they've achieved? A number of times when a patient has achieved a particular moment or a mobility, they tend to go back to the previous state because the entire muscle's integrity is not back to normal. It's only a temporary state where the muscles elasticity or the muscles properties do not allow them to maintain what they have achieved. So here we look at maintaining and going forward with what mobility they have. And then manage and identify the impairment of the patient itself. Now, when we look at a patient for treating, we look at these three important aspects. What are the mobility? What are the different impairments? And how do we relieve the patient's pain? Now, when we look at patient's pain and relieving the pain, the most important approach we use is the stretches and something called the trigger point release. Now, trigger point release is something where it's basically you have a muscle knots, and there are many ways of how we can release them. And then stretches. So as we work on the stretches of different muscles, and I'm speaking about very particular specific stretches for the specific muscles. Like as we took the case study, when she had a fall, she had a severe impact over her gluteus muscles, over her quadriceps, over her gracilis, adductors, and her iliotibial band. So we need to work on very specific stretches for each of these muscles. And going forward, we worked on the stretches which gradually helped her relieve a lot of her pain, which in turn helped her to improve her mobility. And in while at the same time, it helped her maintain what she had achieved. It's not like she achieved maybe 100 degrees of range of motion of the hip flexion, and then she gets back to 5-10 degrees after 3-4 hours. So we maintain whatever we have achieved it. And then the final aspect is the impairments. A number of times patients aren't able to even do the very simple exercise of pelvic bridging because of certain pain, certain restriction in the spine. So we work on identifying those aspects and dealing with them as well. Can you go to the next slide, please? Yeah. So I'll just take you through how did they progress and what have we done through it. So on the day one when I went, the patient was having a lot of pain, was suffering with a lot of pain. The movement was completely restricted due to pain, and basic activities of daily life she wasn't able to perform. And the patient was used, even though when the patient was using the walker, she was still suffering with a lot of pain and she wasn't able to even put one step properly without pain. And I started the treatment with trigger point release and stretches. And by the end of day 5, I found that the patient was recovering slowly with the treatment, and she was able to perform her activity of daily living with less pain, like using the restroom or going to the kitchen, or the waiting of just walking or climbing up or down the stairs was with less pain. And her dependence on the walker had reduced drastically. And then on the 10th day, when we just wanted to recheck how she progressing, then we found that she was recovering significantly, and she was able to perform her daily activities of daily living with less pain, and was able and we were able to wean her off the walker by the 10th day. And even her bed mobility like pelvic bridging, her single leg raise by sleeping on the stomach or sleeping on the sides was much more easier. And she was even able to turn to her sides with no pain at all. And then, as we know, the next step is how we make her stand and walk freely. Then even the standing exercises was with comparatively less pain compared to the day 5th. And on the day 10th, her activities of daily living was with hardly any pain, and she was able to do even her entire movements of the hips and the knees was free with hardly any restriction because of pain. And she was able to perform other complex exercises like standing on one knees, lifting her legs sideways in the standing positions, and she could do all that with no pain at all. And even the patient's gait, it's a way of walking pattern, was improving significantly, and she was able to walk independently with only a slight limp. And by the end of the 20th day, what we found was the patient was able to get back to her normal activities like cooking and other things. She was able to walk with absolutely zero pain, and the limping wasn't there as well. And the patient's overall quality of life was much better, and she was able to come back to at least 95% of her activities of what she had before the fall by the 20th day itself. Yes, Dr. Ake Prasad, hand it over back to you.
Thank you very much, Dr. Kolis. Could we go to the next slide? Yes. So one of the issues that sometimes family physicians, physiotherapists, patients even experience is communication between different professionals. Dr. Ashajit and Dr. Kulis, now you over the course of your working relationship have evolved a form of communication and designed a physiotherapy referral form, which I think pays a lot of attention to the patient goals, which Dr. Kolis was emphasized in his segment. Could you kindly walk us through the physiotherapy referral form that you use, Dr. Ashajit?
Doctor, you are on mute. Please unmute yourself.
Yeah,
Yeah.
Dr. Ashajit. Yeah.
Yeah, thank you. So this is a referral form which we use. This has the name of the patient, her age, and then the date when it was referred. What is the diagnosis? Sometimes the diagnosis we also write as to if the patient is diabetic, hypertensive, because the physiotherapist needs to know as to what the other diagnosis, the morbidities are, the comorbidities. And then the goals, where you have the patient's goal, and also as to what would I like from this physiotherapy. I want the patient to be able, strengthen her muscles, be able to get out of the bed and walk around. So all these goals are mentioned here. And this is a very simple referral form with the goals, which are the short term and long term. So long term, if we want, what do we want? Whether the patient, like what Dr. Collis just mentioned, whether she wants to drive her bike, or is it that she wants to go for shopping, walk around? Yeah, so all that, depending on that, that's the term, the goals, the short term and the long term goals. Yeah.
Thank you, Dr. Ashajit. Dr. Kolis, any comment from your end?
I think just continue to what Dr. Anand has said. The close collaboration or the close understanding between the therapist and the family physician is very important and plays a very key role of how the patient can progress. At the end of the day, our practice is not based on us individuals, but rather keeping the patient at the center of our practice, which in turn helps us understand what's the best for the patient and not for us.
Wonderful, Dr. Kolis. Next slide, please. Now, over to a segment where Dr. Rao will share the family physician's prescription and demonstrate to us a sequence of simple exercises for all of us to stay healthy. Over to you, Dr. Rao.
Before I put the video clip, let me explain how these exercises came into being and why I've started advising these not really exercises, they're stretches actually, to my patients. Many years ago, I met up with a pain specialist who had designed some of these exercises. And then after a few years, the yoga became a rage. And some of these exercises the yogic practitioners do are also incorporated into this. And then a kind of 13 movements evolved over years. And I have been sort of advising and demonstrating these exercises, stretches, to my patients. And I have found a great deal of them, large number of them benefiting with these, when they do these stretches properly. They benefit a great deal. And let me tell you, especially the neck, the shoulder, the lower back pain, hip pain is almost nil amongst these patients. Now then, it is not just those who have a problem should do these exercises, but all of us, whatever age it may be, can do these stretches before they indulge in strenuous exercises, which is required for your fitness. Just these stretches will not give you muscle bulk. These stretches will only stretch the muscles and keep them supple. And your spine, your shoulders, your hip joints will be free to move if these stretches are done. And over years, even at my age, I'm nearly 79, touching 80, I still do these exercises with ease. And no wonder, no, it's no surprise if some youngster does it. But those of you who are nearing my age or even lesser age group, you will find difficult to do these exercises if you have not done them. But over a few months, if you do this, attempt to do this, you will find it's easy to do these stretches. Let me have this video clip right now, please. Now, as I think we should, yeah. Now, you have watched this clip. Now, there are.
Please go back to the previous slide, or yeah. Okay. But you don't have to play the video.
Don't play.
Huh? Thanks.
Now, you have observed that there was this was taken in a kind of a fast sequence. Actually, when you do these stretches, it's a much slower movement than what you see in the video. And then at the end of each stretch, you must hold that position for 5 to 10 seconds. And then you should repeat each of these stretches 10 times. And then if you total the number of times you do each stretch, then the duration would be about 20 minutes to half an hour. You also see that I carried a set of dumbbells in my hands, and that adds to the quality of stretches when you are standing up. Then the weight can be anything that maybe I used 1 kg. You can use, depending on your strength, you can increase the weight of the dumbbells. And the kind of dress I wore is my usual casual dress, but you can wear any easy fitting clothes, except maybe in your three-piece suit, you can't do these stretches. But otherwise, you should be able to do these stretches in any dress that you wear. That means even in your office, you take your coat off and you can do these exercises. How often you should do? I would recommend you do it once, preferably twice a day, but once a day would be enough. And please do them before you start your regular exercises like running or playing tennis or going for a swim or doing any other strenuous exercise which is required for muscle mass building and keeping the strength of your muscles. These stretches will help you to keep your spine supple, your shoulders supple, and move well. And especially those computer guys who work neck and shoulder and in between shoulder pains are very common. If you do these exercises, I can guarantee you, you will not have these pains. So is true with hip and lower back pains. I can definitely tell you that you will not have low back pain and hip pain if you do these exercises properly as they should be done, not in a great hurry. It's very, very important that you take these stretches very slowly and do them properly. You will reap the benefits in the long run. Thank you. RK, back to you.
Okay. Thanks, Doc. Just as a member of society, I'm curious, and I'm sure many others are curious. What is the secret of you staying active, nimble, supple, being able to demonstrate exercises like this at your age? What's the secret?
No, so far so good. I'm not sure about tomorrow, but today it is true. There are several factors that come into play. First of all, you must thank your father and mother for giving you good genes, and that is of primary importance. I've been lucky that way. Then my background. You see, I come from a lower economic background, and I grew up under certain stress. So we didn't have access to any. So I had to use my legs during my school days, and then going to school was walking 4 or 5 kilometers and back. This the only two-wheeler I saw and knew is cycle. So I made use of cycling until my medical school was over. It was walking and cycling only, and very few privileged those days had motorcycles, and I hardly had any medical student who owned a car. In contrast to the present day situation. Now there, and secondly, I was always a sports person, and I spent quite a bit of time playing and indulging in physical activity, and that has stayed till even now. I play, and I do these exercises and stretches, and that's the secret actually. In keeping one fit, one has to spend some time, and what better way of spending than exercising and playing? And also moderate habits, and you don't eat too much, and you don't indulge in too much of alcohol and other substance abuses, and you can remain fit and strong at whatever age you may be.
That's very, very inspiring. We're all really fortunate to have you active with us. So we've come to the end of the session of all this, at least all the speakers speaking. We have 10 more minutes to take some of the questions. And thank you. I want to thank all the audience who've joined us and who've stayed with us over the course of this hour. I also want to thank those who've asked their questions. So I'll go to a few questions that we've received. The first question I see is okay. This may or may not be directly related to the musculoskeletal system, but someone has asked, why have I seen news articles saying that some blood pressure lowering medications might be harmful if I'm infected with SARS-CoV-2 or COVID-19? Either Dr. Prathamesh or Dr. Ashujit, or how about Dr. Prathamesh? Dr. Prathamesh, would you like to take this question?
Yes. So, yeah, there are several of these blood lowering medications when prescribed along with the other medications that most of these people take, especially when it comes to azithromycin or HCQs, can interact and cause several effects because HCQs and azithromycin are mostly known to cause arrhythmias. And if the patient is not being examined well before prescribing, it can lead to several other issues, especially when patients come with tachycardia and fever during COVID. It's really difficult to predict that this person might develop a harm to these medications or things. But I have seen a few patients who have been prescribed on certain beta blockers to reduce the tachycardia, that is, increased heart rate. So sometimes these medications can further lower the blood pressure of the patient as well, causing them to faint, have a fall, and other issues. Dr. Ashujit, would you like to add something from your end?
Yeah, sometimes these antihypertensives also have a small proportion of a diuretic, which can, since COVID is known to increase the blood clotting, yeah, the intravascular clotting. So when somebody is on a diuretic, it further dehydrates and reduces the water content in the blood vessels, and that can increase the intravascular coagulation, what we call. So it's very important to review their medications if if they have been diagnosed, somebody has been diagnosed with COVID-19, then it has to be really reviewed as to what antihypertensives the patient is on. Yeah.
Okay, thank you, Dr. Prathamesh and Dr. Ashujit. There's a question here. So someone asks, I was recently diagnosed with COVID and I'm cured now, but recently I have lymphatic drainage. Can you explain what is lymphatic drainage? And did I get this due to COVID? Could I invite Dr. Rao to perhaps answer this question?
I honestly don't know what he means by lymphatic drainage. If any one of you know, please let me know.
Okay. Okay, but perhaps if perhaps what the person might be asking about is lymphedema or swelling of the legs due to lymphatic obstruction. Would you like to comment? Yeah.
Yeah. You see, I don't think it is. I think it's an independent problem. May not be related to COVID. So there is a lymphatic obstruction and there is an overflow, and then what happens? There will be cutaneous blisters in the skin, and the lymph oozes out because it has no way of getting back into the circulation. It's a very dicey situation, and the only way is pressure bandages applied or venous, the what we call as the venous stockings, which are three grades, and you pressure the subcutaneous tissue and see that the lymph goes back. And also there are some exercises and wherein you do to with your hand to drain. If it is the upper limb, you use your other hand to push that lymph back into it. Normally, you see it in post surgery for breast cancer. Over years, they develop this. So there are these are issues, and sometimes when there is a massive edema, we intentionally drain it outside. That also I have done it in the past. Now nobody does it. But you make small incisions, they are very painful, and the whole thing oozes out. And that is one way of getting. But please remember, this is we are draining plasma and not water, and plasma has protein in it, and you may be draining protein out of the patient's body. So these are issues we can do, but it's a problem which can't be easily sorted out.
Great. Thank you very much. I we have seen, or I have encountered a few patients in whom chronic leg swelling or lower extremity swelling because of lymphedema is a long-term problem. It's a debilitating problem, and it restricts their movement, restricts their confidence. They have swelling, and it can be quite distressing. Dr. Kolis, are there physiotherapeutic approaches to help patients with chronic lymphedema?
So in lymphedema, depending on the location of the lymphedema, there are certain treatments which we work on. There is certain things in which we use, for example, where we just elevate the particular limb at the, like for example, if it's the lower limb, we elevate the leg at above the level of the heart, and then we use something as a crepe bandage. And there's another thing called as stimulation. So what we do in that is we basically apply two pads to two different parts of the limb, and we stimulate it. So what that does is that enhances the entire drainage, which in turn enhances in decreasing the edema itself. So depending on the site of the edema, we work on different forms of treatment.
Okay, okay. Thank you, and thanks a lot. The next question we have, again, this is for Dr. Kolis, is what types of physical therapy protocols are used in long-term acute slash critical care setting? So maybe we'll take it as two different questions. What types of physical therapy protocols are used in long-term care? Could you perhaps answer that, and then we'll take critical care or acute care settings? Go ahead, Dr.
So, so depending on the condition and depending on what's the aim we require. Now, if we speak about, let's say, neurological aspect of it, the protocol will mainly be of avoiding the progression of the disease or reducing the speed of the progression of the disease. So in those cases, we mainly focus on balance exercises, balance rehabilitation, and then we focus on strengthening something which we call as the progressive resistance exercises, in which the patient slowly builds up his energy, his muscle strength, depending on the condition. Again, it's very important. Depending on the condition of the patient, we work on that aspect for the acute illnesses which which the particular person faces.
Okay. One of the things related to COVID and physiotherapy is I have had a few patients who became quite sick with COVID, had to spend time in the ICU, and then developed pulmonary fibrosis, which was deemed irreversible. And many of them I benefited from respiratory physiotherapy. Dr. Kohli, share your experience and your insights on the role of physiotherapy and the what you've seen in terms of its effectiveness, especially in the setting of post-COVID fibrosis of the lung.
So in cases like where you have fibrosis of the lungs and in cases where you have the entire lung capacity itself is reduced drastically. So in those cases, we mainly have to depend on, we have to see what's the patient's current capabilities. And then we need to work on those particular breathing exercises, depending if it's having shortness of breath, different breathing exercises we can work on. And then there's something called as an exercise prescription, in which we work on something called as frequency, depending on how much stamina the patient has, depending on how much capacity the patient has, we define the frequency. That's how long they're able to do the particular exercises. Now, if one example, what I can say is one kid that I have seen, even just we can climb 10 steps up and 10 steps down, his saturation should go below 89, 88. Now, I can't tell him to go and cycle. He will just collapse immediately. So we need to know the frequency depending on how much the patient's capacity is, the lung capacity is. Then we need to see the intensity, how long can they do. Now, if the same person is only able to climb 10 steps, I can't tell him to climb but do 20 steps. It doesn't make any sense. He'll just collapse immediately as his saturation just falls down. So it's depend the intensity, how much they have to do, and how long. If you can take 10 steps in 10 minutes, it's a good achievement in the first day. But if it takes 10 steps in 10 minutes in the 10th day, that is in progress. And then it depends on the type. What type of exercise? Do we say aerobic or anaerobic type of exercises? So it depends on what kind of problem the patient has and what exercise prescription as a physiotherapist we provide them. So as we progress, by let's say the case that I was seeing with pulmonary fibrosis, the first day just making climb 20 steps, his saturation was dripping down to 89 and 90. But by the end of the 10th day of treatment, a regular cardiac rehabilitation or pulmonary rehabilitation, he was able to climb up and down the stairs about 5 times, and still the saturation was about 95. And when we just checked recently, about 3 weeks ago, following up, he was able to go for a 7.6 kilometers jog in just 1 hour. So it depends on how the patient is, what is his progress, and what is his condition at the particular situation. So breathing exercises, exercise prescription is the two main things what we basically use in treating post-COVID patients.
Thank you. And now I'll move to the last question for the day. Again, this is for Dr. Kolis. What is the effectiveness of cycling following physiotherapy for total knee replacement?
If you speak about a total knee replacement, so generally by the end of the third day itself, the patient is able to walk with 100% weight bearing. So it's not like a case where you have a semi replacement where just half of the structure is replaced. It's a complete replacement. So in this case, by the end of the third day itself, you can get back to a normal activity like cycling, jogging, and the effectiveness is pretty good because when you do cycling, it's a form of an aerobic exercise, which basically stimulates your entire lower limb. Whether you speak about your hips, you speak about your knees, you speak about your ankle, it works on all of the joints and it strengthens all of them slowly. At the same time, it helps you in maintaining what mobility you require. Now, when you try to pedal each time, it's not that you're just moving your hips. It's actually working more on your knees because it's helping you flex your knees, bend your knees more often, and creates a sync between the two knees as well. So it's pretty effective after a total knee replacement.
Okay. Thanks, Dr. Kolis. Could we go to the next slide, please? Next slide, please. So to conclude, one of the things I want to highlight is what is home-based primary care and what is family practice. Family practice, especially home-based primary care, is unique in that it recognizes the central role of the patient's context and the interplay of family dynamics, social relationships, cultural background, and economics in both the causation and the presentation of any illness and the response to any given treatment. Next slide, please. One of the things I learned as we were all preparing for this session was that in a country like India, on average, a person spends 10 years of his or her life living with disability. So if the average lifespan in India is close to 70 years, on average, 10 years out of those 70 years are spent with disability. So approaches like we spoke today can go a long way in reducing this burden and enhancing the quality of life of people. Next slide, please. So to conclude, our session objectives were to understand the burden of musculoskeletal problems in the community, which is huge. It's a problem we come across every day. Lots of people in the community may not even complain about this, but may suffer from this. So it's important for family physicians, family members, and physiotherapists to recognize the extremely critical role they have to play. We wanted to highlight the critical role patient education, family physicians, and physiotherapists can play in preventing loss of mobility, independence, joint pain, joint stiffness, muscle loss, and restriction of function, especially among the elderly. And we saw the wonderful sequence of stretching exercises, as Dr. Rao corrected me, which can go a long way in keeping one in both preserving and enhancing function, regardless of age and stage of life. So thank you very much. If you have additional questions, please feel free to contact us. You can contact us either through step 1 or in the next slide. I think there's a phone number given. Next slide, please. Yeah, you're welcome to contact us, or you're also welcome to contact us through the Academy of Family Physicians of India. Thank you very much for this wonderful and engaging session. Thanks to Step 1 and thanks to all the panelists. Thank you very much.
Thank you so much, doctors, for this amazing session that we just had, and thank you, Dr. Rao, for that amazing stretches and exercises. That was really very nice and interesting. And I must thank you all for coming up with the case studies and the patient reviews that made it easy for us to understand what you're exactly saying. And everything was really interesting. I think this topic was a very different yet a very important one to be covered. So thank you so much for doing that for us and taking time off your busy schedule and being here. And dear viewers, I hope you've all enjoyed the session, and which was very informative, as well as we've learned so much today. So stay tuned. We will have one more session coming up the next Saturday. Until then, you know what to do. So you have to go like our Facebook, Instagram, Twitter, and LinkedIn pages, and keep following us. If you want more information on Project Step 1, then log into www.projectstep1.org. I must thank the doctors here. Thank you so much. And Academy of Family Physicians of India, thank you so much for always being with Project Step 1 and doing these amazing sessions for us. Thank you. We'll see you next time. Bye.
Thank you.
Thank you.
Thank you.